Hello, dear students. I am your psychiatry faculty, Dr. Dharmendra Singh, at Physics Wala platform MedEd. So, already you have given the NEET PG exam. It's over. Now you are getting relaxed, and now worry starts for result. So, as I mentioned previously, also that life is full of worries, and there are full of happiness. We can convert these worries into the happiness, doing the things on time in an organized way. So today we are going to discuss the psychiatry MCQs which have been asked in NEET PG 2023. I'm not claiming that these are the exact questions because exact questions we are not getting. On it's based on students recall, but yes, these are the most authentic recall in psychiatry, you can say. I assured you in our sprint session that most probably the questions will come from these areas only, and the all questions of psychiatry I will show you that they have been asked from these areas only, and we discussed all the MCQs in sprint session. So how we can gauge these questions in Indian exams? They don't change the topic, they change the MCQs. So the previous year's MCQs, the hot topics, they are they were the crucial area, and they will be in future also. So for the students who will in future will attempt or appear in other exams, please be careful about it. Yes, you have to understand, you have to go through the all topics, you have to build up the concept of every subject, but the important area, hot areas, you have to focus more. If we'll talk about the first MCQ, they asked in psychiatry, the patient with schizophrenia who did not respond to risperidone and thyroidazine was started on drug A. After starting drug A, patient psychotic symptoms improved. However, he developed excessive salivation, dyslipidemia, and weight gain. Which drug is likely to be drug A? So see, in this MCQ, if you have a concept of the topic, how you can understand this MCQ? Number one, by giving the two antipsychotics, one from the atypical risperidone and one from the typical group thyroidazine. Examiner has given you hint what is the drug for treatment resistant schizophrenia. If you so question number one, the treatment resistant schizophrenia. When we by definition we giving the combination of two drugs at least for 4 to 6 weeks, and patient is not responding to these medications. Response means what? 50% improvement. So by giving this line, examiner given you hint that person is a probably case of treatment resistant schizophrenia. Then he mentioned that we started drug A and patient also improved. After improvement, but the patient developed the side effects like dyslipidemia, salivation, and weight gain. So in treatment resistant schizophrenia, which drug we are using? Clozapine. You know the clozapine is a drug of choice in treatment resistant schizophrenia. Okay, and as I mentioned, I have attached the screenshot also here that I have written during the sprint session that clozapine is the most common cause of metabolic syndrome. It's a we use as an anti-suicidal antipsychotic which has an anti-suicidal property, and I also mentioned that it's a most common cause of metabolic syndrome. Most common cause of metabolic syndrome. In metabolic syndrome, previously we were saying that the which drug increase the weight, which drug decrease the weight, but nowadays we prefer the term metabolic syndrome because in metabolic syndrome, apart from weight, we other criteria, other parameter also we cover. One is what? HDL level, triglycerides, okay, blood pressure, blood glucose level, BMI, body mass index, and waist circumference. So these are the six criteria. We say that if any drug fulfill the three criteria out of six, then we say that that drug is, you know, or any person who is fulfilling the three out of six criteria, we say the person is suffering from metabolic syndrome. And among antipsychotic, the most common cause of metabolic syndrome is clozapine, and olanzapine is second most common cause. The second most common. Please remember that aripiprazole and ziprasidone, the weight neutral antipsychotic, they don't increase weight gain. Okay, briefly, if we'll talk about clozapine, apart from metabolic syndrome, it causes sedation, salivation, which was given in the MCQ. Okay, sedation, salivation, seizure, granulocytosis. Okay, myocarditis, clozapine induced fever. Okay, in sprint session we have discussed in videos, my psychiatry videos also I detail, because from the antidepressant, from the antipsychotic, from uh, antidementic drugs, so from psychopharmacology they ask one or two MCQs every time in the various exams, so I discussed in detail in my psychiatry videos. But in again and again in every class I try to, convey this message that psychopharmacology is very important. So particularly like drug clozapine, drug lithium, some SSRI, antidepressant, they frequently targeted areas from the examiner. So seizure is a dose dependent side effect. Agranulocytosis is a dose independent side effect. Because of clozapine, patient can have a fever either due to myocarditis, due to agranulocytosis because of infection, and clozapine induced fever. So I have discussed in detail that you can go through. So in this MCQ, the answer was clozapine. So see, once you have a good concept about topic, then you can discuss accordingly, and you can think that already it was given that there is a treatment resistant schizophrenia, and the drug A, already you can guess that it was clozapine, and the side effect related to clozapine were given. Okay, so the answer was clozapine. Second MCQ, the middle-aged female presented with complaint of repeated episodes of around 30 minutes, characterized by breathlessness, palpitation, sweating, hyperventilation, and a fear of impending heart attack. The patient has been having these episodes 4 to 5 times per month in the last 6 months, and the investigations did not reveal any obvious abnormality diagnosis. So in this also, how we will solve this MCQ? Number one, complain of number one around 30 minutes, breathlessness, palpitation, sweating, hyperventilation, fear of impending heart attack, and these episodes 4 to 5 times per month. Answer is panic disorder. So it's a patient presented with a panic attack. Panic attack. So how will you know that how you can implement the concept in MCQ? Again, we'll discuss about it. So Panic attack. Panic attack, number one, it's a sudden onset. Sudden onset. Okay. The peak is between 10 to 15 minutes. It can last 30 minutes, 40 minutes as in MCQ is given. Patient will have somatic symptoms and psychic symptoms. Somatic symptoms is dryness of mouth, palpitation, okay, dryness of mouth, palpitation, bloating sensation. Patient will have diarrhea like feeling, sweating, okay, choking sensation, respiratory difficulty, respiratory, and psychic symptom that I am going to die, apprehension or feeling of impending doom. These type of words examiner usually uses. Okay, yeah. So this is about presentation. Whenever we talk about the panic attack, we have two type of panic attack in either organic causes. So we can say organic panic attack or functional. Organic, various medical causes like thyroid profile we go through, we check the blood sugar level, it can due to epilepsy, uh, carcinoid syndrome, pheochromocytoma. Okay, so various medical causes are there of organic panic attack. Examiner in MCQ clearly mentioned that investigation did not reveal any abnormality. So examiner, by giving this hint, made it clear that there is no organic cause. So then it's what? Functional. By definition, when we make a diagnosis of panic disorder, when there is a at least at least 4 episodes per month, then we call it a panic disorder. Panic disorder. Okay. In treatment, if we'll talk about in panic disorder, the treatment of choice is always CBT, cognitive behavior therapy. Medications we use, yes. Drugs we use, SSRI. If they ask you the best modality of treatment, best modality of treatment, then your answer will be CBT plus SS plus, even you can say benzodiazepine, how the examiner will frame the MCQ. Okay, so this is the treatment of choice CBT, drug of choice, that drug we usually use, the SSRI, best modality of treatment, combination of medication plus CBT. Okay, so if you'll go in this MCQ, we'll see that yeah, generalized anxiety disorder. Why can't be the answer? Because in generalized anxiety disorder there will be major criteria and minor criteria, unnecessary worry, and person is not able to control that worry. That is the two important major criteria, and the minor criteria is irritability, restlessness, fatigability, sleep disturbance, decreased concentration. Okay, so these are the minor criteria. So examiner, like free floating anxiety in anxiety disorder, Examiner usually use the word pre-floating anxiety. Anxiety in every domain. So that these symptom description is not given about generalized anxiety disorder, so it is ruled out. There is no symptom of depression. Depression is ruled out. Social phobia, phobia towards the specific object, that description is also not given, so answer will be panic disorder. Okay, so if you have a concept, again, that's why again and again I am repeating in every class that please go for the concept. Once you have a concept, then no need to mug up the things. You have a concept, you implement in the MCQ, and answer is written. See, our exams are so easy to get the paper with the answer. The answer is written in front of you, you have to just rule out. Okay, so the panic disorder is the answer of this MCQ. Okay, next is, yeah, see, this is also in our sprint session. The almost the same, the MCQ was given and the answer was panic disorder. Only one option the examiner have changed. Instead of conversion disorder, it was given the depression, and some language was changed. Otherwise, so the panic disorder we discussed in his sprint session, and then about panic disorder also came. The third MCQ: a husband and wife presented to the OPD with the complaint of premature ejaculation, which is leading to frequent conflict between the husband and the wife. Which of the following non-pharmacological technique is most appropriate for the treatment? So basically, the examiner initially is talking about the premature ejaculation. We will see the question number 3. If we'll talk about the sexual response cycle, there are 4 stages. We have desire, then the second is excitement, the third is orgasm, and the fourth is resolution. Okay, we have a various sexual disorder related to these sexual stages. In premature ejaculation is disorder of orgasm. Yes, orgasm. First, you have to remember. Sometime they ask this premature. Before in DSM-4, ICD-10, they did not clearly mention that how to define the premature ejaculation. DSM-5 mentioned that if the ejaculation occur even less than 1 minute, we call it a premature ejaculation. So according to DSM-5, now it's a clearly they have defined it. Okay, less than 1 minute ejaculation, it's a premature ejaculation. Okay, in premature ejaculation, if you will talk about the drugs, we were using paroxetine and epoxy. Paroxetine is what? SSRI. One side effect paroxetine has, the side effect of paroxetine is delayed ejaculation. And that side effect, dear students, we use in a as a effect in premature ejaculation patient. Epoxetine we developed as an antidepressant, but the half-life is very short and it was not a very perfect antidepressant, and we started using as a the agent for the premature ejaculation. Okay, if we'll talk about non-pharmacological intervention, in non-pharmacological intervention, non-pharmacological in premature ejaculation, we use quiz technique. Quiz technique. Okay, is we it comes under master and Johnson therapy. Master and Johnson therapy, as the name suggests, it's a couple therapy. It's a couple therapy. We use we never treat the patient alone. We always treat with the partner. So in this, we have one is squeeze technique in Master and Johnson, and second we have a sunset focus. Sunset focus that was also given in option. Okay, squeeze technique we use for premature ejaculation, and sunset focus we use for the erectile dysfunction. Okay, in squeeze technique we basically uh, take the partner also in the picture, and we teach the partner that during the intercourse, whenever the male partner having a feeling of ejaculation, that time the with the two finger and the thumb, there is a over the glans penis, the corona, if there is a little female partner suppress, give a little pain, so there is a delayed ejaculation. Okay, in detail in classes we will discuss, but please remember that squeeze technique for premature ejaculation and sunset focus is for the erectile dysfunction. Apart from squeeze technique, the another technique we use, another technique for premature ejaculation, start stop technique. Okay, cement technique also we call it, start stop technique also we use in premature ejaculation. That also we discussed in detail in our sprint session. I'll show you. Even I mentioned there, I mentioned in session that use technique for the premature ejaculation and sunset focus for the erectile dysfunction. Okay, so that also MCQ came from our, we already discussed it. The next MCQ, the 40-year-old patient history of chronic alcohol use present with the complaint of confusion, ataxia and sixth nerve palsy. What is the diagnosis? Okay. In the third MCQ, just see the squeeze technique for, so the answer was the squeeze technique. Sunset focus already I mentioned for the erectile dysfunction, and the exposure and response prevention therapy we use for the OCD, and cognitive behavior therapy we use various anxiety disorder and the depression. Okay. In the last MCQ, the 40-year-old patient history of chronic alcohol present complaint confusion, ataxia and sixth nerve palsy. What's the diagnosis? That also, see, in our session we clearly discussed thiamine deficiency, Goa, it's written the mnemonic also. So that MCQ also we discussed in our sprint session. Already by giving the history of chronic alcohol, the present with the complaint of confusion, already examiner given the hint that person is taking the alcohol and these symptoms are there. What's your diagnosis? And for that we have, yeah, MCQ number 4. Answer was Wernicke's encephalopathy. In Wernicke's encephalopathy, basically we have mnemonic GOA, Goa. G for global confusion, global confusion. O for ophthalmoplegia, and A is what? Okay, global confusion is like a delirium. Okay, ophthalmoplegia due to sixth nerve palsy. Okay, bilateral lateral rectus palsy and ataxia. Okay, so in the lesion in Wernicke's encephalopathy we have mammillary body, mammillary body, and dorso medial nucleus of thalamus. Okay, lesion. And because of that, symptom is there. Yes, if they ask you why it happens, it occur due to thiamine deficient, vitamin B1 deficient. Correct? Vitamin B1 deficient. Because of these symptoms, they occur. If they ask you that in treatment in Wernicke's encephalopathy, first what you give, glucose or thiamine? Please remember, first we give thiamine and then we give. If you will give glucose first, the further use of thiamine, because the glucose will go in glycolysis, further use of thiamine, and further, because further depletion of thiamine, there is a worsening of the condition of the patient. So be very careful. First you have to use the IV thiamine, roughly 1000 milligram IV thiamine we use. IV roughly 1000 milligram thiamine we use. Of course, then we give the glucose. If these patients come on time to us or we treat them sincerely, then we can, we help the patient. If they ask you the first symptom which respond to treatment, okay, it's ophthalmoplegia. That MCQ also they again and again they target this topic, so be very careful. First symptom respond to treatment is ophthalmoplegia within hours. And even you treat this patient very sincerely, 50% patient have residual ataxia. Okay, 50% patient have residual ataxia. Correct? If these patients either don't come on time or we are not able to treat them sincerely, then they convert into what? Korsakoff psychosis. Korsakoff. So you can say that Wernicke's encephalopathy is a less severe condition. Korsakoff psychosis is a more severe condition. Okay, so these MCQ they ask usually. Wernicke's encephalopathy is a frequent targeted topic, so please be very careful about this. Okay, so in this MCQ also, if you'll see that that Wernicke's encephalopathy, Korsakoff psychosis is given. So answer was Wernicke's encephalopathy, Korsakoff psychosis. Why not the answer in this MCQ? In Korsakoff psychosis, basically the confabulation also they give. Okay, the amnesia they will add, like we have anterograde amnesia more than retrograde amnesia. In many conditions we have retrograde amnesia more than anterograde amnesia. Korsakoff psychosis is one of the condition where anterograde amnesia is more than retrograde amnesia. And confabulation, basically patient, it's a more severe condition, so patient forget about the the past some event he or she is not able to recall, but patient also forgets that he forgets. Patient भूल जाता है, लेकिन patient ये भी भूल जाता है कि वो भूल जाता है. So when you ask some patient past event, patient is not able to recall, but patient also forgets that he is not able to recall, so he makes some false story. So this is a confabulation, filling up memory gaps by the false memory. So this confabulation, amnesia, these type of symptom come in a picture in Korsakoff psychosis, which were not given in this MCQ. That clearly they have given the three important symptom Wernicke's encephalopathy, but usually they don't give that easy MCQ in exam. uh, the, Usually they try to confuse with the delirium tremens also. So please remember, Wernicke's encephalopathy also having a one of the symptom delirium, and in delirium tremens or alcohol withdrawal delirium also having a delirium. But how will differentiate them? In delirium we don't have a symptoms like ophthalmoplegia or nystagmus, these kind of symptom we don't have in simple delirium. But in Wernicke's encephalopathy, along with delirium, we have these symptom like. Okay, so please remember this in for future, you can remember it. If you will give any other exams, that we have Wernicke's encephalopathy and we have a usually delirium. In Wernicke's encephalopathy, yes, we have a delirium plus ophthalmoplegia or nystagmus kind of symptom. There is no ophthalmoplegia in delirium. Ophthalmoplegia in the delirium. Okay, and in alcohol that will be a little different topic. But in alcohol, within 7 days, if the person having a delirium like picture, then we say alcohol withdrawal delirium or delirium tremens, or it can happen this delirium after 7 days also, then we say it's a picture of Wernicke's encephalopathy. Okay, so that we have discussed in detail in our psychiatry videos. But please remember here that the answer was Wernicke's encephalopathy, not the Korsakoff psychosis and not the delirium tremens. The fourth option was given. Yeah, de Clerambault syndrome. So de Clerambault syndrome, it's a delusion. It's a delusion of love or erotomania. So it's a different topic. Okay. So these were the MCQs. Some students were saying that, sir, there was a MCQs related to Wernicke's encephalopathy. 2-3 MCQs. One they have asked, about thiamine deficiency related to which enzyme. So please remember the vitamin B1 or thiamine act as a coenzyme in few enzymes, and they are, like, you can say, pyruvate dehydrogenase. Okay, pyruvate dehydrogenase, trans ketolase. Okay, alpha ketoglutarate dehydrogenase. Okay, so pyruvate dehydrogenase complex, we'll say there are three enzyme together there: alpha ketoglutarate dehydrogenase, transketolase. Okay, yeah, so these are the some enzymes where vitamin B1 thiamine act as a coenzyme. So if some enzyme also they can ask, you can give the answer. Okay, and some other MCQs also have been asked, whether the Lewy body dementia or Parkinson disease. But remember, in Lewy body dementia and Parkinson disease, there we have a cortical dementia, we have a subcortical dementia, and we have a mixed dementia. So Parkinson disease is a example. If Parkinson disease develop that dementia, it's the example of subcortical dementia, and Lewy body dementia is a mixed dementia. Okay, cortical as well as subcortical. But in Lewy body dementia, they will give the initially symptom will develop the cognitive dysfunction. Okay, along with the Parkinson symptom also can present, but the cognitive deficit presentation will be early. If they ask the Parkinson disease, then the initially the motor symptom presentation, and then the later on the cognitive deficit presentation will be there. These are the minor thing. So I think that MCQ was answer was Parkinson disease, but the other faculties will discuss and you will be having a more clear picture. Yeah, this time the questions were little less from the psychiatry, but as a psychiatry faculty, I'm telling you, dear students, that yeah, usually 8, 9, 10 MCQs you can expect from the psychiatry. Okay, so be very careful about it. That psychiatry is a very important subject. More that now the next is coming. It's a clinical oriented subject. So if you cover the proper diagnosis, then the psychopharmacology, the dementia, the neurowala part you cover, then yes, 8 to 10 MCQs you can expect from the psychiatry. So don't count it as a minor subject. At 8 to 10 questions, you know giving a minimum input and maximum output is always easier for. So in various techniques we'll discuss in our classes, but yes, the basic and the this minor subject is a backbone of any PG exam. So don't ignore this subject. Okay, best of luck. I hope you have done well, and see you after the result. Okay, thank you so much, dear student.